So should I go ahead and get started?
Yeah, I think you can get started. And then people have their cameras on, which is great. And if you have to like take a break and step away, that's fine. Feel free to type stuff in the chat as well as unmute since we have an intimate crowd tonight.
Awesome. And one other thing, my pronouns are she, hers. I can't figure out how to change it in my Zoom sort of name label right now, but just for your reference. Okay, so since we're an intimate crowd today, all the breakout room things, we'll just sort of do them as a whole group. And so before we hop in today, I just want to give some learning objectives. And so I really want you to keep one overarching question in mind as we go through the session. And so that question is, how does medicine shape and is simultaneously shaped by broader society? And so in this particular session, we're going to turn our attention to the clinical encounter to consider that a bit. And so I provided some readings to the team that that sort of will help you to further engage with that question, gain insights around the clinical encounter and how it's been shaped by things like the general shifting landscape of medical care, including sort of the expansion of certain areas of care, medicine being more corporatized, those sorts of things, as well as these broader sociological and societal and ideological conditions. So feel free to hold those considerations once you get an opportunity to visit those resources. So that said, here are our objectives for the day. So we're going to consider what physicians or other care providers are actually for. What are their roles in society? What do they do and how do they do it? We're going to examine how the clinical encounter again reflects and sometimes reinforces broader social ideology. And then we're going to consider some of the challenges that are presented in the clinical encounter for both patients and providers. Before we hop in, let's just take a little bit of time to chat about what we refer to as the clinical encounter. So what are the goals of a clinical encounter, both for the patient and the physician? You can feel free to sort of jump in as you will.
To communicate effectively.
So would you say that that is both patient and provider's roles or expectations or goals?
I would, yes.
Thank you, Peter.
On the patient side, a big goal is to get treatment or help for the thing they actually came in for.
Yeah, so actually getting some sort of treatment, right?
And then I guess on the provider side for that one, understanding the needs of the patient and where they're coming from.
Yeah, thank you for that, Maya. Definitely important to the provider.
I think on the provider side, time, keeping it to within a certain predetermined time window is a big part of the goal of how they structure the encounter.
Yeah, very important. You only have a certain amount of time as a provider for the clinical encounter, right? And that's shaped by just a whole other set of things that we can explore tonight as well. Any other things?
To create a relationship between the provider and the patient as a basis for their interactions and for a context in which the patient can grasp what the provider is saying and hopefully do whatever is best for him or herself.
Yeah, so thinking about the relationship, and it's sort of important for both sort of the continuity of care, but also for the quality of care and for the patient being able to sort of resolve whatever is going on for them. Other things. Okay, so sociologists have basically considered this question in a few different ways. And so I'll first start by thinking about the role of the medical profession as a whole in relation to the larger functioning of society. So that's sort of a good place to sort of start. So one of the answers to that question around like what is medicine for really comes from a prominent sociologist called Talcott Parsons. And so some folks may have heard of him. So he has this really famous framework called the sick role. And so in Parsons' view, illness isn't just a biological condition, right? Or it's not a characteristic of the body per se or the individual, but it's a social role that comes with these predetermined characteristics, like any other social role, like being a student or being an employee or a parent, those sorts of things, right? And so what Parsons says is he lets us know that most members of society will eventually take on this sick role. And so imagine if one day all of the professors at an entire university called in sick, just for one day. Say tomorrow, everybody calls in sick at your university. Imagine that all of the city bus drivers called in sick same day. No city bus drivers, right? The sanitation workers all are ill on the day of trash pickup. What would happen if something like that happened? What would it look like?
I mean, it would shut down that sector of society. It's not like the sick role isn't considered like a productive role. If they're not working.
Exactly, yeah. So university might have to shut down. Trash doesn't get picked up in one city. That might cause these other things, this catalyst of things to happen, right? So either way, society isn't going to function as normal, right? And so Parsons is saying he's this what we call a functionalist in sociology. And so he is interested in this sort of thing, like how society is basically this wheel, and without all the spokes working, it can't do too much. It's not too effective. So he sort of gives this framework for thinking about that. And he basically says that as a society, we provide this temporary socially acceptable departure from our normal social role obligations. And so he refers to that as the sick role. And so where does medicine come into this, right? So medicine is necessary to maintain social order by policing the sick role, by policing access to it. So we have folks who are considered ill, they're unable to fulfill their normal social roles. And so medicine is the one who helps sort of rein that in. And so we're thinking about medicine as an institution first, right? And then we have to sort of go down a level to think about physicians or other providers as the gatekeepers. So they manage access to the sick role. So not everyone who tries to access the role is automatically granted the sick role. And so here we can sort of see how the power of the physician works as actors in this institution of medicine to decide who's legitimately sick and who's not, who's going to be able to take on the sick role and get a medical excuse and who's not. And so the clinical encounter is the place where this happens typically. And we know that this is sort of shifting for a number of different reasons, and we can discuss why. But basically here we have is the what, the who, and the when. And so without the physician's excuse, you're still wedded to whatever social obligation that you have. If you're a student and you don't have a doctor's note, guess what? You probably still got to show up for school or be accountable for whatever comes of missing that day. For workers, you're still expected to participate in the workforce without a physician's excuse, those sorts of things, or else society is at risk of breaking down, right? So somebody has to manage that. And that's the role of physicians as actors of medicine. And so you don't just sort of get that prize, right? Your responsibility as someone in the sick role is to cooperate with practitioners and try to get well in exchange for that. So those are, you get this sort of thing, you get this sort of prize, but you have this responsibility, right? To attempt to get better, to listen to the advice of your physicians, to do what they tell you to do in order to get better in that clinical encounter. And so I must say that one of my favorite exercises to do with my students in courses is to really challenge Parsons' sick role framework and put it to task. I'll spare you that tonight, but if you wish to entertain that at some point, certainly feel free to go right ahead, especially since Pocket Parsons framework is a bit dated, but it's still considered one that's seminal. And so again, how medicine comes in here is that it maintains order, and the clinical encounter is where that sort of regulation happens. So let's say people end up in the physician's office for whatever problem that they have. So they have a cold, or they have COVID, or they have diabetes. They don't just bring with them that physical problem. They don't just show up with diabetes or COVID. Sociologists say that with the physical, the medical that shows up, there's also a social context that comes with them. And when I say social context, what I mean is all the political, historical, social, economic stuff that patients and people bring with them into any encounter, right? And even though patients and physicians don't necessarily see the clinical encounter as an appropriate space to sort of discuss these contexts or criticize these contexts, these issues still are brought up in medical discourse. And so through this lack of criticism about the context, what really happens is that it helps to maintain existing social arrangements that result in people ending up in the doctor's office in the first place. So things that sort of contribute to people's distress and suffering. And so thinking back again to what I just said about this idea that the function of a physician is to maintain or keep social order and keep society operating as normal, can you see how physicians sort of serve their larger purpose in this way by sort of carteling these criticisms of context in the clinical encounter?
What about people who don't encounter the system at all, who have no insurance, only go there if they have an ambulance kind of emergency?
Yes, that's an excellent point. Let's hold that and come back to that.
I think a good example might be like the current, I think it's Arkansas bill that is like outlawing transgender children from transitioning. And I mean, that's basically in this social political climate dictating what is even a legal medical intervention or kind of care.
Yes, exactly. So holding these ideologies around gender that are tied to these other social hierarchies sort of stagnant and in place by barring what physicians can and cannot do to alleviate suffering for some folks. So I want to come back to what Ken said about what about folks who only encounter the institution of medicine in the case of an emergency. And so y'all are medical professionals or rising medical professionals, right? And so what does it look like when someone's only or typically first engagement or encounter with medicine is in an emergency situation? What does that look like from your end?
I think it gets kind of uh, flippantly describe for providers calling their frequent flyers very dismissingly, that they don't take responsibility for their health, no preventative care, and it's kind of eliding the access, insurance, all of the other barriers that are probably factors in they're only presenting in like acute situations.
Yeah, thank you for that, Taylor. So what happens is folks might come in and physicians are like, like they're not taking accountability for their health in an emergency, and they come in because they come in an emergency situation most of the time. And so what does that response from physicians tell us about, again, how they might be maintaining of existing social arrangements?
So there's definitely an element of validating a complaint through the lens of like what the training teaches you to address. I do think, to the credit of some of the doctors that I've worked with, I think we're sort of living in an era where, and maybe this has always been the case, and this is just when I'm training, but where a lot of social ills are medicalized because of the dearth of social resources and safety net that exists generally. And so people present with sort of the symptoms of the absence of that sort of structure. And I think traditionally physicians have seen their role as more narrow than maybe the public has. So when it doesn't sort of fit what their expectation is of what they're trained to do, it's sort of like, well, there's nothing I can do here. And I do think there are folks who are starting to understand that like people are presenting for a lot more than, the 10,000 diseases that we learn in some, pathology textbook. That there are a lot of other causes that cause people to show up. But there's definitely a contradiction there between what are fundamentally these sort of like social causes of harm and the role that physicians see themselves playing.
Yeah. So as you say, Peter, physicians sort of want to help, right? And so there's this tension that tends to happen in clinical encounters, is that practitioners want to help, they want to, sort of alleviate the patient's suffering, but physicians are also not really trained to deal with sort of the social causes of why people end up there to begin with, right? So you're trained on X, Y, and Z technical, but you aren't really capable of critically engaging or resolving the social, historical, economic context that come in with the patient, those root causes that land them in the clinic, right? So instead, what tends to happen is that as physicians, you sort of offer what you're trained to offer, right? You give them some sort of solution that may be quote unquote superficial, like you give them medication, you give them, some sort of surgery, those sorts of things. And people generally take those treatments and then they return to the same conditions that led to their sickness or their suffering in the first place, right? And so when we think about the clinical intervention and sort of the goals of it for patient and provider, we also have to think about sort of what else is happening there at a more macro scale. And so the clinical intervention, it sort of combines ideology and social control in a number of different ways, which essentially elicits consent to a range of forces of oppression, such as capitalism, such as heterosexism, such as a number of things. And so this process works to further mystify and depoliticize the social roots of sickness, right? And so again, we get back to this point that was brought up earlier, that we're leaving it on the individual to change, to do better, to improve, instead of there being improvements in the context that they're living in that is creating or producing the sickness in the first place. So an example that I want to provide, just to sort of solidify this, and we'll also have an example to work with later, is in the case of this book called Watkins. He's a doctor and a social scientist. And so an example of a case that he gives is there's this encounter with a drill operator. And so what happens is that the physician's certifications, the fact that he's an MD, is what allows him to be excused from his social role obligation of being a worker for some time because of he has back pain, right? And so the physician again is sort of preventing him from malingering. He's telling him, okay, at this point you should be able to return back to work. You'll be healthy at this point. And so what happens is that by telling the patient to go back to work, you'll be healthy, it's good for you to work, he's reinforcing this ideology around economic production that is sort of, you know, embedded in capitalism. And that whatever his job is necessary to maintain stability and social order. And so the physician doesn't really engage the fact that there is a whole economic context that leads to the drill operating being there in the first place, being in this hazardous work condition that's fostered by a capitalist society. That's not what physicians are trained to do, right? That's what typically as sociologists, we're trained to sort of make those critical assessments, engagement. And so that creates, again, as I said, that creates attention for you as a physician because you want your patients to be well, but they also come in with all this stuff that medical school doesn't necessarily train you to deal with.
If I could, Mercedes, if I can comment, I think what you're saying is absolutely true. But the other thing is that doctors have the option to get training in social medicine. There are programs that specifically train us to be more conscious and more active about that. And there are real historical circumstances where medical students and house officers have actually fought the existing social structure. One I can think of is in the 1970s, medical students actually went into people's homes and tested the paint on the walls to identify and publicize lead poisoning. And that was actually the beginning of the movement against or to prevent kids from getting lead poisoning. It's really hard to do. It's certainly not primarily in our lane. And even when we go to do it, there's a real limit on what we can do. But it's an opportunity for people who are activists to think about, what can I do in this setting? What do I know? What am I capable of doing? What am I capable of doing with my peers?
Yes, thank you so much for that, Ken. You bring up an excellent point that yes, there are spaces and growing spaces, right, for physicians to sort of be trained around these issues. And this is, of course, this space is certainly one of them. And I think it's important to sort of consider how those are received within the broader scope of medicine, right? And as you explained, it's sort of difficult to do in a lot of ways. And so that sort of gets to our next sort of question that I'd like us to engage, which is, how are providers trained to address some of the things that are brought in by patients? If folks also had reactions or comments to what Ken mentioned, we'd love to hear those as well.
Can I ask a question kind of in the vein of kind of the previous part? I'm curious if there are like any other models of like what a physician's role in society kind of exists that should maybe like we can strive towards or use as kind of a I guess a role model. I know like the barefoot doctors in China would like help people during the Cultural Revolution, and like the Cuban doctor going door to door giving out COVID vaccines. Is there do you think that like some of the social ills that kind of are baked into how unproductive or like horse blinders are kind of mitigated and like those different political systems that are, at least in name, not as capitalist as America? Sorry, that was a kind of a free-floating question.
No, thank you for that. I don't know. So in a sociology of health and medicine class that I teach, I always end it with sort of, okay, so we've talked all semester about these issues, right? So what can be done? What are alternatives? And we tend to look both internationally as well as some things that have been done by particular groups in America, such as the Black Panther Party, for example, on better ways to do what we're doing. And we'll sort of get to this at the end of the session to sort of think collectively about, is there a better way to do medicine, starting with the clinical encounter? But I have to say, of course, I don't have one answer to that. But I'd love to hear what other folks think. And we sort of hold that for the end as well. But for now, it might be helpful to think about how, at present, how are providers trained?
If I can just interject, that it's a relationship between the residents. Residency is sort of a classic time when people do activist work, and the first 2 years of medical school. But in residency, what I observed was that the doctors had ideas, and they were constantly in struggle with the administration, whether it was their department chair or the person above the department chair, or the person above that. So, for example, in my program, which was mostly in a Puerto Rican neighborhood, we basically lobbied the administration to teach us medical Spanish, because none of us spoke any Spanish and all of our patients did. And it took over a year, but we finally got it. That's sort of a microcosm of the things that we struggle with.
Yeah, Ken, exactly. You bring up a great point, is that that within an institution, right, there are individuals who are attempting to push against this existing culture and structure, right? And that can be very difficult. I'm not in medicine, but I'm in academia, and like a similar sort of thing happens, where it's sort of a push against conventional ways of thinking, what are considered canons, what are considered the right perspectives, right? And so thank you for mentioning that a lot of students, sort of residents, sort of saw the gap in like what was happening and what they had been trained, and saying there needs to be some type of fill-in here. There needs to be a bridge for us to effectively do whatever it is that we're here to do, and really lobbying for that.
So one experience that I have is that Gordon Schiff was an internal medicine attending at Cook County Hospital for 30 years. And he wrote an article in JAMA a few years ago about the difference in the culture between how the doctors related to the patients at Cook County Hospital. And he's now currently working at Brigham and Women's Hospital in Massachusetts, in Boston, which is an upper-class WASP hospital. And the kind of informal, friendly interactions that he had with his patients, he actually got brought up on charges for behaving that way at Brigham and Women's Hospital. And he wrote about that experience, and people can find it in JAMA.
Thank you for that. Yeah, sharing that sometimes cultures are different, even within hospitals or within different clinical settings. Any other considerations for how physicians are trained to deal both with patients and sort of on a general level, and specifically with the issues that patients might bring in with them?
I think that like physicians are increasingly trained to at least ask about the things that are affecting patients' health outside of like their physical ailments, but the follow-up isn't there of like how to connect people to care. Like we aren't really doing like warm handoffs in clinic, bringing people. Sorry, my cat is pooping right now, so you can hear that. Just ignore that. But okay, he's too loud. Okay, I'll chat.
Thank you for that. Yeah, So I'll just read what you said over here. Oh, Vikram says he thinks it depends a lot based on specialty.
I think, you know, in my experience so far in school, there is a growing awareness around this, you know, in part to sort of the growing body of literature that speaks to its importance, that being kind of like the language of how doctors talk to each other. But you know, I think a lot of the incentives as a undergraduate medical student in particular, there are these sort of hard science oriented tests, like high stakes tests, and you know, assessment drives learning. And yeah, I know a lot of my experience was classmates that had sort of a social focus coming into medical school were able to preserve that social focus and find outlets. You know, in my case, this group is one of those. To grow that. And for folks that didn't, you can sort of sit there and do note cards through a session on the social determinants of health and basically face no educational consequences for it, and perhaps even be rewarded for it because of a high performance on a high stakes test that is ultimately geared towards, you know, the individual, like what's going on from a you know, biological, pathophysiological perspective of the one patient who's sitting in front of you. And so I do think a lot of the, you know, while there's, to Kami's point, while there's like a growing awareness of it, or dialogue around it, the structure of it is still very much geared, you know, oriented towards that, like one patient, real disease and fake disease. And we work on the side of, you know, real, and I say with air quotes, like we work on the side of real disease. And yeah, I think a lot of structure is that way still.
Yeah, so Peter, you bring up a good point as well, sort of to Ken's point earlier, that there might be these sort of individual efforts like that happen with groups of students or particular students, but again, that dominant sort of framework still exists around how to do medicine and what is necessary to be a good physician, right? And so I wanted to sort of backtrack and see if you wanted to elaborate on your point about it depends on specialty.
Sure, I can. I just wasn't sure. I don't know if you can hear. I'm like in a car, so it's like driving. But as long as you can still hear me fine, it's cool. Can you all hear me?
Yeah.
Yes, we can hear you.
Okay, cool. Yeah. I mean, I think it depends a lot based on specialty, and the reason I said that is because like what you choose to care about as a specialty physician depends based on like the amount of work you have related to that. So like if you're a surgeon and you're doing like 6 to 7 surgeries a day, you're not really, the time that you have to like actually think about doing, like looking at the patient's, what the patient's going through and everything else is not really like your primary concern. And especially if you're doing like surgery for like tertiary care patients, like at this point, like the patient is like at the point of intervention where we're saying about addressing patients' needs was well before that, something that like likely a family physician could handle better and likely would handle more, because they see patients before they get really, really, really sick. And so I think that that's a part of it. And I think the other part of it is what I said about specialties. I think depending on the specialty you're in, they give you more or less time to focus on these things. And so just on a structural standpoint, no matter how much you care about this, you may not have enough hours in the day to focus on it. So that's just another aspect I think that really differs, that really like makes that difference for specialties as well.
Yeah, thank you so much for that. Yeah, that there are sort of different points in which a physician or a practitioner might be intervening, right? And might it make sense to sort of address particular things based on where you're intervening? As you mentioned, sort of, primary care might have been the place, but we also know there's not like a true and a lot of incentive to be in primary care, right? And so what do we do with that? I don't mean for y'all to answer that right now, but just something to think about. What do we do with issues like that? I want to transition now. I'm sorry, I muted myself. Um, to sort of think about a particular section of the clinical encounter, which is the medical interview, which I'm pretty sure most of you are familiar with in some capacity. And so, what tends to happen in the medical interview?
The way that we're taught is we're supposed to have open-ended questions. There's the patient-directed portion of the interview. Then you transition over to the physician-directed interview. I think the med students probably practice the patient-directed portion a lot more than the like seasoned physician will. And the general questions, I think, get more specific when the physician has like uh, a preconception going into the room.
Thank you for that, Taylor. I want to ask a follow-up. Why do you, this to you or to the rest of the group, why do you think that it might be the case that med students and sort of seasoned physicians approach the medical interview differently? Any speculation on that?
I think there's a couple of aspects to it. One, is just like logistically. I mean, at first, med students were given like 30 minutes to interview a patient. In an actual clinic, you get 10. Maybe if you're behind, then maybe you want to like catch up and I go faster. And then I think as you get more confident in your like medical reasoning, I think that can build some just like hubris, or you think that you know what's going on just by looking at the patient, and that's not a good reason. Neither are good reasons, but I think those are happening at the same time.
I think we go into the room into like a new encounter, thinking of the information that we need and not necessarily like everything else doesn't really matter. Like, what are your complaints? Like, why are you here? And just tell me that, and we don't need to know anything else about going in your life. I think a lot of like, I feel people that I work with like, oh, you'll get better at like navigate, like pushing them to like a certain way, or like cutting them off. Or like redirecting them as you go along with experience. Because I feel like in medicine, we're focused on like, what is your problem? And we just need to know about that, not necessarily about your family or something like that, something that we don't think is relevant or related.
Yeah, thank y'all for that. So y'all brought up a couple of things that I just want to reiterate. The first one is that the physician is sort of the expert, right? At the end of the day, they're going to decide what's going on. And so the physician is trying to glean whatever information that they think might be relevant, what they need to know. And then the other one is that Taylor mentioned was about the fact that you really have 10 minutes, 10 to 11 minutes in an encounter. And so you don't really have time to sort of allow the patient to get to wherever they're going. You're like, I need to know this. I have this amount of time to do that. And those sort of tell us a number of things. And so one of them that I'll sort of circle back to is the fact that the medical encounter is so short. And the reason why that is so short is it didn't just happen by circumstance, right? It happened because of a lot of different structural things related to the corporatization of medicine, right? What some sociologists sort of call the assembly line of medicine that we sort of see today, this sort of 10 to 12 minute encounter is in the name of efficiency. We need to see as many folks as possible in this short amount of time. We don't have all day. And so in the medical interview in particular, right, physicians are sort of exercising control as the expert by structuring the exchange between them and the patients in the medical interview. And so the practitioner is basically using their position to structure the interview, right? They sort of ask, the patient responds, they get to decide what's important and what's not. And so there's this bias in the focus of the physician, right? They're constructing and deciding and specifying relevance of whatever information the patient is providing. And so as y'all are sort of alluding to, that life context sort of is often sort of, sort of shelved away and not considered as significant for whatever the reason that the person is here. There's a focus really on the physiological, medical side. And as far as the physician's questions, they're defining the relevance of those, of what the patient offers. Any thoughts on that? What are the implications of the physician deciding when and how non-clinical, and I say that in air quotes, factors matter?
It depends on how the sort of presenting condition or issue with the patient is defined, and what other resources exist to sort of like remediate what's going on. I don't think it's not always, I think that years of experience in clinical medicine can provide a useful sort of like ballast of information to guide to structure interviews. That if somebody comes in with, doc, my ankle hurts, and then they're taught, but I read on Google that it might be connected to like this danger that I've been having, and this person had seen a bunch of broken ankles can be like, I can, that's not a relevant piece of information here. We can bring that back, which is, I basically had that happen today in a patient encounter, a little bit different, but basically, and that can be appropriate sometimes to structure, to really try to identify like a problem visit. I think the issue is when like we only validate complaints that can be defined in a medical language, and then we only address like the most immediate presenting downstream portion of that. It's sort of a way to say like, well, you've gotten help and they couldn't do anything for you, so it must be your fault. It's a like, I don't know if I'm like describing that very well, but like when the sort of like funnel of like addressing grievances is like narrowed down to a total medical gaze, and then that meets with like the training that is where you only have the tools to address really like medical problems, it trims away everything else from being sort of taken as a either political, like valid complaint, or the political implications or structural implications of like where that issue came from.
Yeah. And so you sort of mentioned at the individual level what that could sort of look like or funnel to. So at the more broader societal level, what might a pattern of this sort of, what might be the implications of that? Of the physician getting to decide what's important and what's not.
I guess in general, like it contributes to this dynamic of physicians holding the power. And I guess one thing that I'm also thinking about is kind of the flip side of that, like physicians also get to decide what social factors are relevant. And I think that can similarly lead to like relying on bias or thinking about somebody's like a part of somebody's identity in a way that like, I guess I'm thinking about if somebody comes in with something unrelated to, or seemingly unrelated to like a substance use problem, but they also have that in their history, what that means for that patient, and the fact that the physician gets to decide whether that's relevant or not in that context, I think also is important.
Thank you for that, Maya. And you mentioned sort of two things happening at sort of at the micro level and sort of more largely, which is that number one, the physician is sort of, there's a power imbalance there. There's already typically a power imbalance that exists for a number of reasons, like class status might be different, educational statuses might be different, racial statuses might be different, gender might be different, right? And so there's already that sort of inherent power imbalance that might exist. And then the physician encounter, right? When we think about medicine, the only person who can tell a physician if he is doing his job properly legitimately is another physician, right? And so we have to think about that as well. And so somebody mentioned the medical gaze, right? And besides the medical interview, the gaze is instituted through a series of medical practices, right, that are common and instruments. So it's this focus really on the individual, not necessarily as a person, but a case of something. So doctors are really getting all this information and they're producing this knowledge around a patient's body, but in that the patient as a human sort of gets lost. So traditionally what ultimately happens is that through the gaze and sort of medical discourse associated with it, you sort of transform like people into these generalizable cases of something, like a case of HIV, a case of diabetes, a case of X, Y, or Z, instead of them being like, Carmen or Lauren or whoever. They could become like this case, right? Any thoughts on that? Or ways that you see medicine sort of reproducing that dynamic?
I feel like I've definitely seen this in surgery. And I feel like as a med student, I feel like sometimes I feel like I'm more aware than like a seasoned surgeon of like the person. I like to think that. I remember there's been like cases where I'm like so into whatever surgery is happening that like when it ends, I'm like, oh shit, there's a person underneath like the sterile field. That even though like I'm really new in this field still and like don't have the experience, like even with me that I thought I was like so much more aware of this, it still happened to me where I was like, what do I even know about this patient apart from the surgery that they're having? So it happens a lot.
Yeah, and there's assistance with that, right? Like having a drape or, like those sorts of things sort of aid in that sort of, erasure of a person to the point where they might become invisible, right? But when we can't see the patient, what happens is that the rest of them gets marginalized. That again, going back to that context that they're bringing with them, that can easily get marginalized as well. And so one of the things that's important to think about is there are three aspects of the medical gaze that are highlighted in one of the pieces that I provided. And essentially the first one is that physicians are taught to value the objective things, like things that they can actually measure through tests or observe themselves, right? Over the patient's sort of explanation of what might be going on. Because again, the physician is considered the expert. And with expertise, you sort of get to decide is what the patient's saying legitimate or is it not? I can go with what they're saying, or I can go with this test that I just ran. The second thing that happens is something that was mentioned earlier, is that sometimes patients are inadvertently blamed for whatever suffering they have. So that blame can often take the case of they're not, taking their meds correctly. Sometimes folks' culture, quote unquote, is blamed as being problematic for whatever reason. Sometimes perceived differences in people's bodily makeup are blamed as well. And so we really have to think about how that reinforces hierarchies at a number of levels in society. So if we're sort of, really saying that like someone's culture is problematic and it's causing all these, health issues, then we can sort of see how that reinforces like racist or xenophobic ideas. And again, this can stem from the fact that patients don't really have time to explain, or physicians don't have time to explore how structures are imprinting themselves and affecting the body. And so, of course, the logical conclusion in a lot of cases is that it's the patient that's doing something wrong, not some sort of structural thing that's going on. And the sort of third aspect gets at structural violence. And essentially, there's a lot of work on how structural violence really victimizes the patient, but the physician also is sort of getting beat up in a lot of ways, in different ways by structural violence. And I just want to stop for a second and sort of clarify what I mean when I say structural violence. What I mean by that is the systemic ways that we think about social structures, like whether they be economic, social, or political, the way that they're creating harm for people as in individuals or groups of people, whether they be racial, ethnic groups, that sort of thing, or whole societies, right? And so I'm sure we can think of a ton of different examples of that. But when I say that the impact, when I talk about the way that physicians are sort of caught up in structure, it's really sort of visa this neo-capitalist, neoliberal capitalist like system that I've been sort of talking about all along, that focuses on profit, that creates these conditions that really constrain how physicians practice medicine, that they're sort of pushed to participate in this assembly line. That's one example of that there is a short amount of time, 10, 11 minutes, where you are expected to learn all these things and make a diagnosis. That creates, really terrible conditions for the physician as well. And that, again, goes on to impact care delivery. So y'all have sort of shared some of this, but I do want to consider a case. So let's consider a patient, male patient, he's having headaches. What questions are important for you to ask? What do you ask? What sort of information do you need from him as he presents in your office?
What brings you in here today?
Yeah, so why are you here? Where does it hurt?
I would ask when he gets the headaches, what he's usually doing when it happens, if he's done anything that makes it better, if anything makes it worse, if he has any other pain anywhere else.
Yeah, so associated or related pain, anything that makes it better, worse, what brings them on.
I would go through, what to me would indicate this is a medical emergency or not. I think would also be the first questions I would ask.
Yeah, trying to figure out if it's an emergency. Other things that might be important to ask.
Anything he's concerned about in particular, what he thinks might be causing the headaches?
Yeah, what he thinks is causing them, where are they coming from for him? Other things.
I think that's a good point of what Taylor said. Like, what is he most worried it is? Because a lot of people Google headache and find like brain tumor, and then they have that in the back of their mind. And I think if like we don't understand that and like find a way to assuage that fear during the visit, then that's like a key thing that gets missed.
Yeah. Sometimes WebMD can be your worst nightmare. Um, okay, so here's a little bit more about our patient. So he's been having these headaches for over 7 years, and they keep coming back. And he sort of gives where they're located, top center of the head. Sometimes it feels like it's behind one eye. The other day it might feel like it's behind the other eye. It's not made better or worse by drinking or eating, drinking water or eating, by resting, by standing up, by sitting down, by painkillers of any sort. And they tend to be brought on for him at work after being insulted by his supervisor. He's a migrant worker who works in a strawberry farm, and being told things to, like hurry up when he's already going as fast as he feel like he possibly humanly can. And for him, he says that the only thing that makes it better is for him to drink almost 2 dozen beers at night so that he can relax and not yell at his kids and his wife. So what's going on here from your perspective as a physician? What's the cause? What's causing these headaches for this long and to be this bad?
Social conditions. Stress is what we would call it.
Stress. Other thoughts on what's going on here?
I think there's like a possibility that whatever pesticides he uses that are around the strawberries could be influencing his headaches. So it's another, I guess, social condition you can't necessarily change.
Potentially the pesticides, yeah. Other things.
I mean, I would of course be worried about the effect of drinking that much beer every night on somebody's health as well.
Yeah, so there's the drinking part as well.
I'd really like to focus on upstream, what's causing his supervisor to treat him like shit, because it feels like this is internalized anger. He'd love to lash out, but he knows that that'll harm him in the long run.
Yeah. So what we sort of see here is really structural and symbolic violence, sort of where folks who are oppressed or dominated have, they've been in one hand convinced that the harm that is being inflicted on them is sort of inevitable or natural because they're at the bottom of, the ladder. It basically becomes embodied in and results in things like headaches. It results in some type of sickness or suffering for them. And in this case, it's debilitating headaches after being, berated while picking strawberries. And so, as y'all have noted, there are for sure social forces at play, right? That really regulate him to the to sort of live and work at the bottom of these labor hierarchies, right? As a migrant worker. Those didn't happen by accident. There are political and social and economic reasons that contribute to the type of work that he does, and also how he's treated by superiors. And so he's of course subjected to, racial slurs, work demands that are impossible. And so, as Al pointed out, these headaches are socially structured, and then he in turn drinks, and that creates tensions for him and his family, and also inevitably, it inadvertently contributes to him embodying racialized stereotypes of Mexican migrant workers. And these stereotypes are the very ones that work to legitimize the existing racial and ethnic citizenship hierarchies on strawberry farms. So as a physician, What do you do about this? What can you do as a provider?
Go find the on-call social worker.
Oh, we have to consider citizenship. This is really hard, huh?
I mean, I think these situations are something they give me a certain amount of anxiety about the career I have ahead. You know, I know and have been already just in my one clinical year, like be confronted with a lot of things where that are like this, where there is like a really clearly identifiable, like structural predisposition to what's here in the exam room. And I think that, there's a certain feeling of frustration and powerlessness that can come when you're sort of like confronted with the full sort of economic and political and social force that's causing the harm that you're experiencing in your exam room. And I don't have a good answer, because you would love there to be one, but I don't have a good answer of what you would do. It depends on the resources that you have access to, and the specific conditions that you're working in.
Yeah. Yeah.
I think what Peter's describing is why a lot of people who feel that way end up in public health. When I started a public health residency, I didn't even know it existed. I called somebody for a job and they said, "Oh, you must be calling about the public health residency." Public health docs have a different set of problems, but they have a lot more leeway to look at upstream issues and causes. And the classic example of how people get into public health is they practice for a while and feel frustrated about not being able to get to root causes or even close. Because it's the way our profession is structured, it's almost impossible to do anything that will affect those upstream causes. The best we can generally do is work in clinics where we take care of people who are poor and don't otherwise have access.
Yeah, you bring up a great point. That was certainly my entree into public health. I have a whole nother perspective now. I'll keep that. But but yeah, for sure, you feel constrained by the structure of your field, where you're like, so what am I supposed to do with this shit? I'm supposed to go and eradicate racism today, xenophobia today, imperialism today, so that my patient can not have these issues. It's heavy.
I'm curious as what like different people's like risk benefit analysis would be like if you can't get at the like social root cause, which I mean everyone wants to do, and I think there might be like little ways you can start even organizing, but like treating the individual. I think a lot of like the mass prescription of like SSRIs and like maybe like naloxone for his drinking, or like a benzo for if he's having like anxiety attacks. I mean, you're really putting a medical band-aid on the situation, but I mean, you might be putting him in a little bit of a better situation. But I think that's kind of it's self-defeating almost. Like you can almost I just close your eyes to a social problem and say that you fix an individual.
Yeah, excellent point, and a definite point of, again, it's that tension, right? That a lot of people want to go into medicine because they want to help people, and then you sort of run up against almost like a brick wall because of these interlocking systems of oppression that are often at play. And so when we sort of think about this, I want you to take a bit of time to think about what is and versus what should be. So again, we're using our imaginations here. Take about 2 to 3 minutes to just free write on that. So just write and don't sort of self-edit. Think about how things are in clinical encounters from your experience, or either as a patient or as a provider, or as a resident, versus what they should look like. And so I'll sort of keep the time on 3 minutes for that. Sorry to interrupt you again. I just want to say that you don't have to pose any solutions in your free write. Just give yourself the imaginary space about what should and could be in medicine. Okay, so if you're still sort of wrapping up your ideas, that's fine. But I'd love to hear from folks if you're interested in sharing. Sort of where are we versus where you think we should be?
I see the clinical encounter as a place where we ask questions, gather information, and then guide conversation to distill a person's like recent physical experiences of their body into a few treatable and also quantifiable conditions that we can manage. And then like what it should be is a broader, I guess, space of healing for the patient where, well, that's as far as I got because I didn't go deeper, but I'll think. But yeah.
Thank you for sharing. Other folks want to share their thoughts? Maybe someone we haven't heard from today.
Sorry, I was muted. I wrote that the medical encounter right now is like rigid. Like the word like protocol came to mind. Like we have protocols for everything and like these like flow charts that we follow that make these encounters kind of rigid in my eyes. And what it should be is kind of like the opposite of that. It should be something fluid, that kind of flows between the parties involved, and that is like one-sided as it can be.
Yeah, so what I sort of hear you saying is more fluidity, more collaboration between provider and patient. Okay, yeah. Other folks. Oh, I see Ken's comment down here. Do you want to share your comment, Ken?
Yeah, my comment was that one of the things that we can do is while we're learning to be doctors, we can learn to be organizers. And I got to tell you, that is not an easy task. The hardest thing that I have ever seen doctors try to do is learn how to be organizers because of the attitudes that we bring to our interactions with people. We're generally much more comfortable with asymmetric interactions. And it's hard to stop being arrogant because everything around us teaches us to be arrogant. However, I have seen some people who have done fabulous work because they really either it's who they were and always were, and they enjoy talking to people, or who actually went to trainings and read about how to be a good organizer. We can join various kinds of movements in our cities and states. I mean, I was once involved in a hospital strike where I was the one who brought the coffee and donuts. That was a role that I could play effectively because I'm not that good an organizer. I'm active in the movement for Medicare for All, which is essentially an educational and mobilizing thing that some doctors do very well. But it's a steep uphill, but it is something we can do to allow ourselves some freedom within the structure of our medical training and our medical institutions.
Yeah, I appreciate that so much, that we all sort of have a role to play. And it might not be the same as our colleagues, but we all have like a role to play, not just in the you know in the sense that we're sort of constraining that to the institution of medicine, but understanding that inequity exists sort of everywhere, it sort of moves everywhere. And so we need to be sort of involved in this ongoing struggle, these ongoing struggles that exist for a more equitable society and for justice. Other thoughts that folks would love to share? We love to hear them.
So one of the things I wrote about is like one of the things that the clinical encounter is it's a legitimized space for identifying a certain type of complaint and trying to, if there is a complaint, pick out the piece of it that is individualized, treatable, using the sort of the tool set, often pharmacologic, that the physicians are taught to use, and sort of reducing it to that. And in that space, it has access to an enormous, it has this like sacrosanct role as like, this is the okay place for problems to exist. And because of that, it has access to an enormous amount of resources, right? You can prescribe medications that cost hundreds of thousands of dollars a year, or a hospitalization that might, just like an enormous amount of resources can be deployed, provided it fits like into this sort of predetermined lane of acceptability. And I think one of the things that it should be is just like one component of a larger healing ecosystem where there are multiple different types of grievances or maladies that are held as like valid and equal and worthy of redressing. And so I would like it to see it take on less of a significance, because other parts of identifying what hurts about the world take on more.
Yeah, I love that there's this more holistic, that it fits into this more holistic thing, right? And that there is, thinking about sort of what hurts outside of the individual encounter, but also sort of what is hurting people maybe in non-physical, non-physiological way as well, and treating that as valid. Okay. So one of the so we sort of talked about a number of different things today, and so one of the attempts to address some of this and do some of these things that we're talking about and address these non-clinical issues that impact health in general and healthcare delivery are things that health professionals and people in my other sort of field of public health have tried to do sort of of course before this decade. They've tried to consider things like cultural competency, which I don't know how many folks are familiar with that sort of thing. Who's sort of heard of that and knows what it is? Cultural competency. Anyone want to like give us a really like quick and dirty definition of cultural competency?
How about to be listening hard enough and be knowledgeable enough and humble enough to realize that you haven't a clue what's going on inside somebody's life?
I wish it were that broad. Yeah, I wish it was that inclusive. But essentially, it's sort of this idea, and I know in med school, y'all kind of like competencies are everywhere, I'm sure. But it's essentially this ability, right, to understand and sort of interact with people from different sort of belief systems and cultures and races and all this other good stuff that are different from our own. But over time, some folks are like, well, I don't know if that's quite enough. So how might the idea of cultural competency fall short? Just from a provider's perspective. Well, one thing I'll say is that how in the hell can you be confident in a culture like that like idea, like I can't wrap my brain around it. Like I can like check boxes and be like, okay, I'm confident in Black folks, I'm confident in like like whatever, like in trans folks. Like it doesn't, like that whole idea is just kind of like, how does that, how might that work? But beyond that, cultural competency also fails to examine the culture of medicine or biomedicine and really engage the structural determinants of health and healthcare, right? And so a lot of times, as we've been sort of discussing today, that it's sort of the way that medicine as an institution is structured and the cultures that exist within it that are the actual barriers for effective care sometimes, once folks actually make it to some sort of medical interaction, right? And so the sociologist, he and his co-author call for training around physicians or practitioners having some sort of being able to do some sort of social analysis. And he calls this structural competency, right? How many folks have heard of this before? I know it's been around for a little while. Yeah, so a few of y'all. And so part of this is considering again how these isms come into the medical encounter with the patient, for one, and also how the medical encounter or the clinical encounter doesn't happen in a vacuum, that it happens within these broader structural contexts that shape these interactions. And so there's been a ton of research on the ways in which physician bias happens. There's a ton of research on, racism and sexism and heterosexism and all these other things, transphobia, like sort of happen in the medical settings and in clinical encounters. And I've shared a piece on racialized sexism in clinical encounters, and so it might be helpful to look at that. But it's important to think about how these things sort of impact medical encounters and the decisions that are made within those encounters as well. So I definitely recommend looking at this piece. It's incredibly short. It outlines 5 components of structural competency for medical education, but I just want to highlight the last one, that final component of medical competency, which is basically recognizing the limitations of calling this a competency, right? Like there has to be a critical understanding that we're constantly learning and things are constantly evolving, and that you have to be aware of that. And there's no way to be like confident in like the way that you know like everything about everything as it relates to structural inequities and how structures are functioning. Even as a sociologist who legitimately studies structure, like I can't even do that. Um, and so as a med student, it's and a practitioner, it's important to recognize that and really embrace humility and think about the ways that you're constantly learning and listening and collaborating with physicians, with people who are patients, and those sorts of things. And in addition to just sort of speaking and leading because you have an MD and a white coat on. And part of that also is being realistic about the endpoints of medicine and the physician encounter or the clinical encounter as well. And so today we've explored the clinical encounter through considering both the medical interview, the medical gaze, and how those things are sort of related. Um, and in this examination, we've basically been able to really think about and see how these broader social forces really shape not just the institution of medicine at this sort of bigger level, but also at the more interpersonal level as well. And so as an exit activity, I think it might be useful or helpful at this point to revisit that initial question that I posed about how medicine shapes and simultaneously is shaped by, this broader stuff. Um, and so taking all of that and taking all that we've discussed today, incredible points that y'all have shared, I invite you to take 2 minutes to, again, just free write about how you can use this as you approach the rest of your education, your residency, and your future practice. So let's just take, again, a couple of minutes to do that. Again, you don't necessarily have to create some elaborate solution for fixing everything. You don't have to do that today. Okay, so I won't ask you to share that, but I will sort of encourage you to revisit that sort of note and revisit this, same question as you get to, pivotal moments in your career, in your education, where you're sort of like, why am I even doing this? What's my role in this? And as I sort of mentioned earlier, we all have a role to play. And it's often something that I sort of pose to my students at the end of the term, who have been pre-meds a lot, that what's sort of your role and sort of creating a more equitable society, a more just society, and really fighting for health justice. What does that look like from your perspective? Because we know, of course, and it can be daunting that these, really big structures exist and they've been around for what seems like almost forever. But they were, they didn't just pop up out of nowhere. They were created. And so if they're created, then they can be dismantled. And, as individuals and as groups of individuals, we can all, of course, do our part to push against these structures and make them a little weaker. And so that's all I have for y'all today. I just want to thank y'all for being so attentive and for being here. It's certainly been a pleasure. Here's my email address if you have questions or would like additional readings or whatever. Feel free to contact me at any time. That should be my email until I graduate this summer and finally get my PhD. But thank y'all for being here and engaging.
Thank you so much, Mercedes. I really enjoyed talking with you and reflecting, and we're so thankful that you spent the last couple hours with us.